My name is Michael Betel, and I am the president and founder of the Fatty Liver Alliance. We raise awareness about the risk, causes, and complications of fatty liver disease and help those already diagnosed with MASLD and MASH by advocating for access to approved treatments and care. Today, in part 10 of our series, we're diving into an important topic, current and emerging treatment options for MASLD and MASH. To guide us through this discussion, I am honored to introduce my very good friend, Dr. Naim Alkhouri. Dr. Alkhouri is a transplant hepatologist and serves as the chief medical officer and director of the fatty liver program at Arizona Liver Health in Phoenix, Arizona. Dr. Alkhouri, your work and the research conducted by your teams have provided hope and clarity to so many patients. What insights can you share today to help patients better understand the treatments available now and what's coming on the horizon?
Thank you, Mike, as always, for having me, and thank you for everything you do for our patients with MASLD and steatotic liver disease. I think this was a historic year for the Fatty Liver Alliance. You've been to all the major conferences, and your presence has been felt by all of us in the community. You always produce great videos, educational videos for providers and patients and their families, and we all appreciate you. And I am very excited. 2024 has been a great year for us, and we have major developments that were presented at the AASLD meeting in San Diego. I just came back a few days ago, very energized to continue the work that we do, and I'm going to share some slides with you. What's on the horizon for MASLD and MASH, new treatments and innovations? And I want to start by saying again, 2024 was a historic year in MASH. We had the first FDA-approved medication with resmetirom being approved on March 14, 2024. This is indicated for patients with MASH, fatty liver with F2, F3 fibrosis. So they need to have what we call significant fibrosis or scarring of the liver. At the AASLD liver meeting also, we heard the positive results from the ESSENCE phase 3 trial with semaglutide. And this medication could be FDA approved next year in 2025. So now we had the first medicine approved in 2024, potentially the second medicine in 2025. So things have never looked better for our patients with MASH, fatty liver disease. I have a new mantra in 2024, which is just do something, because we can do a lot now for our patients. And the do something is the three S's that I keep focusing on. S number one is please screen for fatty liver disease, MASLD, MASH, in all patients with high risk. This includes all patients with type 2 diabetes, all patients with medically complicated obesity, and patients that meet the criteria for metabolic syndrome. And you need to be actively screening these patients. It cannot be just based on elevated liver enzymes. This should be done in the primary care clinic and in endocrine clinic and in any clinic that sees patients with type 2 diabetes and metabolic syndrome. The second S is stage the disease. Once we make a diagnosis of MASLD, we need to know if they have significant fibrosis. And this is more important than ever, because now we have these effective treatments. So it's going to go beyond just a comprehensive lifestyle intervention. In addition to healthy eating and exercise, now we have effective medications that can be used in combination. And the third S is start treatment, because we have the treatment today. And we always try with the lifestyle intervention. But when we fail and the patient is progressing, now we do have effective treatments. So please don't forget about the three S's in 2024 and 2025. Now, at the AASLD meeting, I want to start by presenting some data on semaglutide. This is what we call a GLP-1 receptor agonist glucagon-like peptide. This is a hormone that we make in our intestines, and it regulates insulin sensitivity and appetite and gastric emptying. And this has been successfully used to treat type 2 diabetes and obesity. And we have these two indications by the FDA. So I want to share some data from the ESSENCE phase 3 trial. These were data that were presented just a few days ago. This was a large phase 3 program that included in part 1, 800 patients with biopsy-proven disease. with stage 2 and 3 fibrosis, so significant fibrosis. And in part 1, these patients were treated for 72 weeks, so a little bit over a year, with a high dose semaglutide, the dose we use for obesity. After an up titration, the max dose was 2.4 milligram, and this is given as a weekly injection. So this is, again, the same compound that we have in Ozempic for type 2 diabetes and Wegovy for obesity. And this is the Wegovy dose for obesity. And then all these patients had the biopsy after 72 weeks of treatment. And then we continue to follow these patients for a few years to see if we can prevent liver outcomes. And this was the primary endpoint from the Essence trial, so very positive results. You can see on the left, this is the rate of MASH resolution. So MASH is the aggressive form of fatty liver disease, and to see that we can resolve it in close to 63%, this was very encouraging. We always have what we call a placebo arm. So you see the treatment arm is in blue, placebo is in pink, and there was a delta of close to 29%. So definitely semaglutide led to higher rates of MASH resolution than placebo. And then also, very importantly, there was a significant improvement in liver fibrosis. So we're talking about a reversal of the disease now, going from stage 3 to stage 2 or stage 2 to stage 1. And I hear this question a lot from my patients in clinic when they say, well, you're telling me I have fibrosis, and I heard that fibrosis is irreversible. And I always have to tell them, no, actually, fibrosis is completely reversible, especially if you catch it in stage 1, 2, 3. Cirrhosis is sometimes reversible, but when it's very advanced, it'll be very difficult to reverse. So going back to the data, when we looked at fibrosis regression, improvement by 1 stage, this was achieved in 37% of patients, and this was significantly better than placebo. So very positive results, and we see that semaglutide hit on both primary endpoints, the NASH-MASH resolution piece and fibrosis regression. We also looked at resolution of NASH and improvement in liver fibrosis, and this was achieved in close to 33% of patients treated with semaglutide, with a delta of about 16% from placebo. We looked at change in body weight. We know that semaglutide leads to weight loss, and the weight loss was around 10.5% with semaglutide compared to only 2% with placebo. And then we looked at improvement in quality of life, and patients on semaglutide felt better because they lost weight, they had better diabetes control, and their liver disease also improved, and there was improvement in some quality of life measures. We also looked at liver enzymes, what we call ALT and AST and gamma GT, and there was a significant improvement in all of these in the semaglutide arm compared to placebo. And then we looked at what we call non-invasive tests. So these are tests like FibroScan to measure liver stiffness. We call it vibration-controlled transient elastography is the scientific name. We also have 2 blood-based tests called enhanced liver fibrosis, or ELF, and then procollagen 3 or ProC3. And if you look at these biomarkers, you can see that all of them improved in the semaglutide arm, and the dark blue compared to placebo and the light blue. So this gives us more reassurance that it's not just the biopsy that's getting better, but it's actually liver enzymes, liver stiffness, and biomarkers of liver fibrosis. So very encouraging data. And I think based on these data, the plan is to file for FDA approval in 2025. And I look forward to being able to prescribe semaglutide to our patients with MASH and F2 and F3 fibrosis. Moving on to resmetirom, which is the FDA-approved medication. This is what we call a thyroid hormone receptor beta, or THR beta agonist. This medicine mimics the effects of the thyroid hormones that regulate metabolism, but only inside the liver. So it makes the liver more efficient at using fatty acids, and that can help defat the liver and decrease liver injury and also fibrosis scarring. So we have data from the Maestro NASH trial. This was the large phase 3 trial that led to FDA approval, where patients were given placebo versus 2 doses of resmetirom, 100 milligrams or 80 milligrams daily. They all had biopsy at baseline showing MASH with fibrosis, and then a repeat biopsy after a year of treatment, looking at something we call NASH resolution or MASH resolution and fibrosis regression. So this is the design of the trial that led to resmetirom approval. This has been published, but we looked at a subgroup of patients within this trial that were actually on a GLP-1 receptor agonist like semaglutide, and we wanted to see if these patients had different response than patients that were not on a GLP-1. So this is important because we want to make sure that even if you're on a baseline GLP-1, that you still responded to resmetirom and you had the same rate of NASH resolution and the same rate of fibrosis regression. So the patients that were included were on a baseline GLP-1 therapy for at least 6 months, and they're stable. In the trial, they're all diabetics, and the most common dose was the 1 milligram of semaglutide. So this is lower than the dose that I just shared with you in the Essence trial. And some of them were not on semaglutide. They're on comparable GLP-1 agonist. So patients on the GLP-1 therapy compared to patients that were not on it, the GLP-1 patients were all diabetics, whereas in the trial, it's about 68% that had diabetes. They had also more advanced fibrosis, scarring stage 2. They had the same amount of liver fat, but they had more metabolic and cardiovascular risk factors. They're more likely to be on a cholesterol medicine or statin, and they actually had lower cholesterol, LDL cholesterol, and liver enzymes. And the most important finding in this study was that actually being on a GLP-1 receptor agonist did not impact the response when you're started on resmetirom. And we see this on the left when we looked at NASH resolution, GLP-1 versus no GLP-1. There's really no difference in the rates of NASH resolution. And you can see the resmetirom arms in brown and orange compared to placebo in blue. And then when we looked at fibrosis improvement, also there was no difference if you're on a GLP-1 or not. So I think these data are encouraging because they showed that even being on a baseline GLP-1, once you add resmetirom, you still had the added benefit of achieving NASH resolution and fibrosis improvement. We need to understand that not every patient on a GLP-1 is going to respond, and some of these patients will continue to develop fibrosis that will progress from F1 to F2 to F3 because all these patients were on a stable GLP-1, yet the baseline biopsy we did in the trial showed that they have MASH and significant fibrosis for the most part. So another important study, and it shows that maybe in our clinics in the future, we will be using combination therapy of a GLP-1 plus resmetirom and other new medications. In the last couple of slides, I want to show data from another program with the medicine called efruxifermin. This is what we call a fibroblast growth factor 21 or FGF21. This is a hormone mainly produced in the liver. It has multiple effects within the liver. It leads to less fat going inside the liver cells, and it also affects the adipose tissue or the fat tissue that we have in our body. So it has multiple mechanisms of actions. And at the ASLD meeting, we had additional analysis of a trial called the Harmony trial. These were patients with MASH and significant fibrosis on liver biopsy, and they were treated for 96 weeks. They had a biopsy at baseline. They had another biopsy at 24 weeks or about 6 months. And then what I'm going to show you now is the results from the biopsy at 96 weeks. So about 2 years of treatment with this new medicine called efruxifermin. And this is what we found after 96 weeks in terms of the fibrosis improvement. I want our audience to focus on EFX 50 milligrams. So this is efruxifermin at 50 milligrams. This is an injection once a week. And I want you to look at the fibrosis response rate at 75%. That means that 3/4 of patients that were treated with this medicine for 2 years achieved a regression of fibrosis by at least one stage. So this is remarkable. This is the highest rate of fibrosis regression we've seen in a clinical trial. And actually, up to 1/3 of these patients achieved fibrosis regression by 2 stages. So they go from F3 all the way down to F1. So very encouraging results. We also looked at fibrosis biomarkers. So you see the same ones I showed earlier with the enhanced liver fibrosis ELF going down significantly with the medicine, efruxifermin, and also liver stiffness on transient elastography FibroScan going down very nicely. And finally, I want to show this, what we call a Venn diagram, looking at the response with all the biomarkers we have. So here you see the liver stiffness, fibrosis improvement on the biopsy, histologic improvement, and then the enhanced liver fibrosis, which is a blood test. So again, this is looking at the biopsy and also the imaging test, the FibroScan, and the blood test ELF. And I want you to look at placebo, where on like 0%, none of the patients achieved improvement on all three biomarkers. So some of them had improvement on the biopsy, but there was no improvement on the FibroScan. Some of them had improvement in the blood test ELF, but no improvement on the biopsy. And again, none of the patients achieved improvement in all three markers. And then we move on to the efruxifermin 50 milligram weekly dose, and you can see that 42% of patients achieved improvement in all biomarkers. So you go from 0% to 42%, and actually all the patients had had improvement in at least one of these biomarkers. So very encouraging results. I think we learned throughout the years doing clinical trials and in our clinics that liver biopsy may have limitations. We learned that the blood test ELF, the FibroScan, they have their own what we call prognostic values, so they can predict outcomes even when we don't have a biopsy to compare them to. So to be able to see that, a very high percentage of patients were able to achieve improvement in all three markers is really encouraging for me as a liver specialist. I know these patients will have regression of their disease, and hopefully they will never progress to cirrhosis and its complications. So I just want to leave you with this slide that was presented at a satellite symposium at the ASLD liver meeting. I presented this with my dear colleagues, Dr. Mina Bansal and Dr. Maru Ranella. And again, our message was just do something. There's a lot to be done. And for our patients, I want you to know what we want to happen if you are at risk for MASLD. So please bring this up with your providers, whether it's your primary care doctor or endocrinologist, and ask them, did you screen me for fatty liver disease? And if they tell you yes, and you have fatty liver disease, say, what is my stage? I need to know my stage. Do I have significant fibrosis? And then if they say yes, you need to tell them, hey, you need to start me on treatment. There is effective medications. We have resmetirom available in the United States now. I think it's going to be approved in Europe next year, and hopefully the rest of the world quickly. And then we have semaglutide that potentially can be approved to treat MASH with fibrosis next year. And then the future looks more bright than ever. We have several other compounds. I don't have time to go through all of them. I just give you an example with efruxifermin, but there are many encouraging data points that were presented at the ASLD meeting with different mechanisms of action. So I am very encouraged to be in this field, and really, it's a powerful position to be in. When I see patients now with significant fibrosis, I say, if we do everything we're supposed to do, you do your part with the lifestyle intervention, I do my part with monitoring you and using medications, that we will prevent you from progressing to cirrhosis. Thank you, Mike, again for having me. Always a pleasure.
Thank you. That was really incredible how you went through some of the key highlights. Can we go to the big screen? There we go. Thank you. Oh, I thought I lost you for a sec. Thank you for going through that in great detail. I also thought, and you did deal with that at the end too, what patients can say to their physicians when with all these new molecules and new treatments coming. Maybe they're unfamiliar with it, the physicians that they're going to. I just wonder if you have any advice for patients when they go to their doctor, as you said, and ask to be screened. For patients that are already know that they have MASLD and MASH, what can they do to encourage their physicians to connect them with a clinical study? And I know you would know that better probably than anybody.
Yeah, I mean, we do clinical trials, and I think, I'm always very thankful to our patients that decide to participate in a clinical trial. I tell them when you do a phase 2 or 3 trial, you're not only trying to help yourself, but you could be helping millions of people down the line. I think one thing is to actually, again, ask about how advanced the disease is. And again, that word stage, you need to know the stage of your disease. And if they tell you that you have, significant fibrosis, stage 2, stage 3, there's, FDA approved medications, but we also have clinical trials and we are developing several medications. And one thing that, the patients can do is to go to a website called clinicaltrials.gov. And this actually lists all the trials for any specific indication. And then once you find these trials, you can actually scroll down and it will tell you the locations for the trial in your state or your country if it's a global trial. And then typically there's a phone number and a contact person that you can talk to. Also ask your doctor if they know that, there's a place or, a clinic where, they're doing clinical trials. They might be able to connect you. But again, clinicaltrials.gov is a good resource for patients. Also, we have several, websites. So, Fatty Liver Alliance, you have also American Liver Foundation, Global Liver Institute, and sometimes they have, listings of clinical trials that are enrolling patients. So, the patient advocacy groups, they are very helpful. And reach out to all of us. I mean, I think we're all passionate about this. So I'm sure, Mike, if someone reaches out to you, you will know how to connect them in what city in the United States with people that are doing clinical trials. And then, also chat with your peers and patients that have similar stage of fibrosis. If they're, going through a trial, possibly they can refer you to a trial center. So a lot can be done. Clinical trials are a very good way to take care of this disease. You will receive the best medical care out there, and you'll have access to medications that we cannot prescribe today because they're not FDA approved. And last thing about clinical trials, I always tell my patients, you're not going to be a guinea pig. Okay, we've tested these patients typically in hundreds of other subjects. We know a lot about their safety, what to expect in terms of adverse events, and we have encouraging efficacy data. But to get to FDA approval, you need to test these medicines typically in thousands of people for an indication like MASH. But again, your principal investigator, the research team, they are aware of the possible adverse events. We keep a close eye on every possible side effect, and you can stop the trial at any point you want, no questions asked. And then sometimes we tell you that we need to stop the medicine. So we do everything very transparent. We share with you everything that we know. There's always risk. I don't want to minimize it, but I just don't want you to think that you're going to be a guinea pig. You're going to be a research subject that is treated with respect and appreciation, because participating in a clinical trial is very meaningful for you as a patient, but also for the community.
Thank you very, very much for everything that we discussed and that you shared. I'm sure it will help so many patients. And I know that we're going to talk again and we're going to keep an eye on what's coming down the pipe.
Thank you, my friend. Yes, I'm excited for the program that you're organizing in December also. So more to come on all these topics.
Thank you. Thank you.
Thank you.